Hello, everyone, and welcome to our podiatric pathophysiology group assessment. Today, we'll be looking at a case study that focuses on a real world clinical scenario. Throughout this presentation, we'll explore the relevant laboratory tests and imaging techniques used to investigate our patient's symptoms. We'll also discuss why we chose the certain imaging modalities, their strengths and limitations, and how these tests help us reach a more accurate and confident diagnosis. Our goal today is to take you through the clinical reasoning process, from the patient's presentation and initial assessment, through to the diagnostic imaging choices and the rationale behind them. The patient we'll be focusing on throughout this presentation is Daniel. Daniel is an elite sprint hurdler training 6 days a week. He presents with gradually worsening pain around the navicular and tibialis posterior insertion, especially during push-off. He is 6 weeks into his training after he came off a 4-week post-season rest. He has no prior history of navicular injury and is suspected he has a navicular stress fracture or either tibialis posterior insertion tendinopathy. The possible diagnosis of a navicular stress fracture is suspected, as Daniel trains 6 days a week, and this injury is commonly associated with overuse and repetitive loading of the navicular bone. Furthermore, Daniel's rapid return to high-intensity training following a 4-week rest period increases the likelihood of a stress fracture, as these injuries often result from a rapid increase in training loads or intensity. To help guide diagnosis, a clinical test known as an end-spot palpation test can be performed. This involves palpating the dorsal surface of the navicular bone and checking for tenderness, a common indicator of a navicular stress injury. However, it's crucial to remember that a positive or negative result from this test cannot confirm or exclude a navicular stress fracture. It simply helps guide our diagnostic thinking, and imaging is always required for confirmation. The second possible diagnosis is tibialis posterior insertional tendinopathy. Daniel's report of pain during push-off is significant, because that's the phase of gait where the tibialis posterior tendon is under the greatest load. Over time, the repetitive strain and microtrauma can lead to tendinopathy, especially in athletes who train frequently without sufficient recovery. To gain a further understanding, the single heel raise test can be done to support this diagnosis, where patients stand on one leg, raising and lowering the heel, and if there is pain or inability to complete the movement, it supports dysfunction of the tibialis posterior tendon. When considering imaging for Daniel, it's important to choose the most accurate and appropriate technique, one that provides accurate diagnostic information while minimizing unnecessary radiation exposure. Our choice of imaging should be guided by physical examination results. For instance, if Daniel's end-spot palpation is negative but his single heel raise test is positive, the pain is more likely tendon-related rather than bone-related. In this case, a musculoskeletal ultrasound will be the most suitable imaging option. Ultrasound has no ionizing radiation, is readily available, and provides a real-time assessment of soft tissue structures, including the tibialis posterior tendon. It allows us to evaluate the degree of tendinopathy, detect partial tears, or observe thickening of the tendon, all common in overuse injuries. Conversely, if Daniel's end-spot palpation test is positive and his single heel raise test is negative, the concern shifts towards a navicular stress fracture, and a plain X-ray film will be the preferred first line of imaging, as it has a much less dose of radiation in contrast to other imaging modalities and is more accessible. However, a limitation of using an X-ray is that early navicular stress fractures may not appear on X-rays, as it can take up to 6 weeks after the onset of pain for navicular stress fractures to be visible on an X-ray. And given Daniel's onset of pain was 6 weeks, there's a possibility it won't be visible on the X-ray. Therefore, if Daniel's X-ray results are inconclusive, an MRI would be the next suitable imaging modality for his diagnosis. as an MRI is considered the gold standard for diagnosing early stress fractures, as it is highly sensitive for detecting bone stress reactions, which are early indicators of a stress fracture before a clear fracture line appears. Additionally, an MRI can also assess soft tissues including the tibialis posterior tendon, allowing clinicians to evaluate for tendinopathy. Therefore, MRI provides the most comprehensive and definitive diagnostic assessment in this case, as it allows clinicians to confirm or rule out both diagnosis of a navicular stress fracture and tibialis posterior tendinopathy.
Here is the decision-making tree we would like to use for diagnosis. The patient presents with medial midfoot pain that worsens over time, combined with the patient's physical activity pattern, which suggests a higher likelihood of tibialis posterior insertional tendinopathy or a navicular stress fracture. To differentiate between these two conditions, several physical examinations can be helpful. For tibialis posterior insertional tendinopathy, single leg heel raise test or resisted plantar flexion with inversion can be used. If the result is negative, an ultrasound examination is still recommended to avoid underdiagnosis. If the test is positive, the pain is likely due to tibialis posterior insertional tendinopathy. Musculoskeletal ultrasound should be used as a first-line imaging modality because of its excellent ability to visualize soft tissues such as tendons and muscles, assess vascular flow to detect neovascularization or inflammatory hyperemia, and its good affordability. However, ultrasound is highly operator dependent, which means ultrasound interpretation relies on the operator's ability to identify subtle changes in tissue structure. An inexperienced examiner might miss small lesions like early stage fracture. This could cause a false negative result. If ultrasound findings are positive, the diagnosis of tendinopathy can be made. If the findings are negative, the patient's symptoms should be reassessed. If the pain is resolved, tendinopathy can be excluded. If the pain is still there, MRI is recommended. MRI is a gold standard for visualizing non-bony structures and diagnosing tendinopathy. A positive MRI confirms the diagnosis, while a negative MRI rules out tendinopathy and suggests that other causes should be considered now. For suspected navicular stress fracture, palpation over the end spot is a typical physical test. A negative result doesn't rule out a stress fracture. Therefore, an X-ray should be performed to avoid underdiagnosis. X-ray imaging is a gold standard for identifying most fractures, but early stress fractures may appear normal. If the initial X-ray is negative, it's important to consider whether the patient belongs to a high-risk population and whether the affected site is a high-risk location for stress fracture. If the patient is at low risk or the site is at low risk, a repeat X-ray should be performed after at least 3 weeks. If the second X-ray becomes positive, a stress fracture can be diagnosed. If it remains negative and the symptoms have resolved, a stress fracture can be ruled out. If it remains negative but pain persists, an MRI is recommended now. Although navicular stress fractures are relatively uncommon, we still put this patient in high-risk category, as studies show that hurdlers experience more foot fractures. Therefore, he needs further imaging. Historically, the bone scan was a gold standard for early stress fracture detection due to its nearly 100% sensitivity, but it lacks specificity, as other conditions, such as tumors or infections, can mimic fractures. Moreover, Bone scans cannot accurately define fracture patterns and have largely been replaced by CT or MRI. When advanced imaging is required, MRI should be prioritized. MRI is a gold standard for diagnosing most stress fractures because it can detect bone marrow edema and medullary changes in the very early stages, before a clear fracture line develops. A negative MRI can effectively rule out stress fracture. If MRI results are inconclusive, CT should be used. Compared with MRI, CT provides superior visualization of cortical bone and is more effective at identifying longitudinal fractures. However, CT cannot detect bone marrow edema and evaluate transverse fractures well. In the case of navicular stress fractures, CT is particularly valuable because it can identify discrete lucent or sclerotic fracture lines and periosteal reactions that may be difficult to visualize on conventional X-ray or MRI. CT scans are therefore considered the gold standard for diagnosing navicular stress fractures. A negative CT result effectively rules out a navicular stress fracture.
X-ray imaging strengths and limitations. X-rays are primarily used for imaging bones and joints, and this is where they excel compared to other imaging techniques. Radiation exposure from X-rays is measured in millisieverts, MSV for short, with foot X-rays typically using less than 0.01 MSV per image. X-rays have been a cornerstone of medical imaging for decades and remain a quick, painless, and non-invasive method that is also relatively low in cost. The procedure only takes seconds, and the radiation passing through the body is not felt by the patient. However, X-rays have several limitations. They provide only two-dimensional images and have poor soft tissue detail, making them unsuitable for visualizing muscles, tendons, or ligaments. While the radiation dose from a foot X-ray is very low, repeated or excessive exposure can be harmful over time. X-ray test metrics and factors. In Daniel's case, an elite sprint hurdler presenting with a bone navicular stress fracture and tibialis posterior insertion tendinopathy, an X-ray could help help identify the bony injury, but would not reveal the soft tissue damage due to its limited contrast resolution. Therefore, while an X-ray is practical for Daniel because it is fast, affordable, and non-invasive, it would not provide a complete picture of his condition. To achieve an accurate and comprehensive diagnosis, the X-ray should be complemented with another imaging modality, such as an MRI, which can better assess the surrounding soft tissues and tendon involvement. CT imaging strengths and limitations. CT scans produce detailed cross-sectional images of bones, making them a highly useful tool for identifying Daniel's navicular stress fracture. One of the primary strengths of CT imaging is its ability to visualize complex and anatomical regions that are difficult to assess using X-rays. It is particularly valuable for accurately grading the severity of a fracture and assessing cortical bone integrity. Over time, technological advancements have allowed CT machines to perform faster scans with the ability to freeze motion, meaning they can capture rapidly moving structures such as the heart by acquiring hundreds of image slices per second. Furthermore, CT settings can be adjusted to produce thin or thicker slices, typically around 2 to 5 millimeters, depending on the region of interest, improving flexibility with diagnostic precision. Despite these advantages, CT has several limitations. While excellent for bone and joint imaging, it provides poor soft tissue detail, making it less effective for diagnosing tendinopathies or ligament injuries. CT also exposes the patients to higher levels of ionizing radiation, around 10 MSV per scan, significantly more than conventional imaging methods. Additionally, the machines are large, costly, and require special operators, which can limit availability and increase wait time for patients. CT imaging test metrics and factors. CT scans use computer algorithms to reconstruct tomographic images, enabling precise multi-slice imaging. From a practical and patient-centered perspective, a CT scan is appropriate for Daniel due to his elite athlete status, as it provides a quick and detailed assessment of his fracture and assists in creating an accurate return to training plan. However, because CTs cannot effectively assess soft tissue injury, Daniel's tibialis posterior insertion tendinopathy would require an additional imaging modality such as an MRI for a complete diagnosis. MRI imaging strengths and limitations. MRI stands for magnetic resonance imaging, and it is considered as the gold standard for visualizing both bone and soft tissue injury within the same scan. MRI scans utilize the H2O molecule in the body, which contains two hydrogen ions. The MRI's strong magnetic field causes these protons to absorb energy, and as they return to their original state of relaxation, they emit a radio frequency signal that is detected by the scanner. This process generates highly detailed image without using ionizing radiation, making MRI safe for repeated use across all populations. MRI can visualize bone, edema, tendons, and soft tissues, making it one of the most versatile and widely used imaging techniques. However, it also has certain limitations. Patients with metal implants such as pacemakers cannot undergo an MRI scan due to the magnetic field. Claustrophobia may also be an issue, as the enclosed scanner environment can cause anxiety. Additionally, it is generally advised that women in the first trimester of pregnancy avoid MRI scanning unless absolutely necessary. Availability can sometimes be limited, and the cost remains high. Through recent advancements, this has improved both accessibility and affordability. MRI test metrics and factors. From a practical and patient-centered perspective, MRI imaging is an excellent option for Daniel, as it provides accurate, comprehensive information with minimal health risk, supporting the creation of a precise recovery and return to training plan. The only potential barrier for Daniel would be claustrophobia, though this can often be managed with reassurance or open MRI systems. For professional athletes, MRI is typically the first choice imaging modality due to its ability to assess both bone and soft tissue structures in a single detailed scan. Thank you for listening to our presentation.